Good evening and welcome to the chapter 3 of part 7. Here we'll be discussing the electrical activity of the heart. So if my audio and video both are clear, then we'll start the discussion. Yeah. So I welcome you all for the next class of part 7 chapter 3, that is electrical activity of the heart. Here we shall be discussing two important aspects. One is the action potential of the heart, and the second one is the ECG, understanding of the ECG or the basics of ECG, or you can call it EKG, the electrocardiogram. All right. So friends, as I already discussed in the part 7, I was discussing excitable tissue, wherein I discussed the action potential. I was telling you that a cell in a normal state is polarized. Polarized means outside the charges, outside the cell the charges are positive, inside the cell the charges are negative, and this is also termed as the resting state of the resting membrane potential, or the difference of charges. Here we are calling it as the resting membrane potential. But what will happen if a stimulus comes and hits the cell in the form of ionic changes, in the form of opening up of channels, in the form of a nerve coming and stimulating? Like last class I told you about the neuromuscular junction. I told you the two different neurons, they synapse with each other, like how do they communicate with each other. So anything might be the stimulus. Once the stimulus comes and hits the cell membrane, so this causes change in the potential difference, and now the positive charges move inside the cell, and you are calling it as the cell is depolarized. Depolarization means the cell has gained I'm really sorry, there is some problem with the video. Give me a few seconds to settle this down. Yeah, I think I'm back. So we will be discussing the I was discussing, the stimulus comes and arrives like this, and it causes, just one second, it causes depolarization. Depolarization means positive charges are moving inside the cell and the resting membrane potential is disturbed. It means that the membrane has gained positive charges. It means it has previously it was negative. From minus 70 it has become minus 40, it has become minus 30, then minus that, like that it is nearing the zero, and sometimes it crosses zero and becomes plus values also, plus 10 or something like that. Sorry. Really sorry. Yes. So sometimes it becomes positive also. So after that, what happens is continuous movement of positive charges inside the cell. Continuous movement of positive charges inside the cell will make the resting membrane potential to achieve equilibrium, and now no more depolarization occurs. At one point of time, repolarization starts. It means that the positive charges start moving outside the cell, and thus again from plus 10 to 0, from 0 to minus 30, from minus 30 to minus 40, like that potential again comes back to minus 70 millivolts. So this I already told you. Why am I discussing this again is to understand one important concept of the properties of cardiac tissue. Please remember that unlike skeletal muscle depolarization, the important differences I told you in my last class, but now we'll try to understand those differences in much more details, because we are discussing only the heart, activity of the heart. So what are the properties of cardiac tissue? The cells within the heart are specialized to do different roles. It has got different functions to do. The most important one is automaticity. So important function is automaticity. For example, if say suppose this is the right atrium, this is the left atrium, these are the ventricles, we have got interventricular septum like this, all right, right and left ventricle. So somewhere here we have got the SA node. This SA node has a property of automaticity. Firing begins automatically from this cardiac cell called as SA node, sinoatrial node. SA stands for sinoatrial node. Sinoatrial node. Spontaneously action potentials begin to occur, and these are action potentials in a circular fashion. They discharge into the surrounding neuronal circuit. All right. Thus, when this SA node cell fires, action potentials are moving across from one point to another. Thus depolarization also starts moving. So the function of this SA node is to stimulate the entire atrium like this. First it stimulates the entire atrium in a circular manner. It undergoes depolarization. After that, what happens? There is another node present in between the junction of atria and the ventricle. Because it is present at the junction of atria and ventricle, you are calling it as a atrioventricular node or AV node. All right, these are the group of specialized cells, neurons or specialized cells, which are electrically active in the heart and which are supplying electrical function to the heart by depolarizing the different tissues. From here, the bundle of His starts. So this is the bundle of His bundle. It has got two branches. It has got right branch and the left branch. The continuation of the stem of the bundle of His, you are calling it as left branch. So this is the left bundle of His. This is the right bundle of His. Right bundle of His spreads and starts supplying the entire right ventricle like this. And whereas the left bundle of His again divides into anterior branch and a posterior branch. Anterior superior branch and a posterior. This again I'll teach you when I am teaching anatomy. So here bundle of His has got right and left branches. Again, left branch is divided into anterior and posterior branches. So as you all know that we do not have such a property is not present in skeletal muscles. All right, once the stimulus starts from the SA node, it spreads across the atria. From the SA node, it goes to the inter or intra-atrial fibers, or we also called as internodal fibers. There are three branches of internodal fibers. We have got a branch of Thorel, a branch of Bachmann, and a branch of Wenckebach. From here, the impulse reaches the AV node. From the AV node, the impulse reaches the bundle of His. From here, the impulse goes to the right and left bundle, right and left branch. From here, the entire right ventricle is stimulated. The left is divided into anterior and posterior branches, and these two supply the left ventricle. And the terminal fibers, we call it Purkinje fibers. So terminal fibers of this are called as Purkinje fibers. J is silent in this, Purkinje fibers. All right. So as from SA node, the impulse begins. From the SA node, the impulse begins, and it is going to the internodal tract. From there to the AV node, from there to the bundle of His, from there to right and left branch, from there to the left to the anterior and posterior branches, from there to the Purkinje fibers. So last one to receive the impulse or depolarization is Purkinje fibers. The first one to depolarize in this cycle is SA node. Where is SA node present? In the atria. So first one to depolarize is the right atrium, then the left atrium, then the AV node. In the AV node, what happens is there are specialized cells which are composed of numerous gap junctions. Last class I told you what are gap junctions. So in case of gap junctions, what is happening is the impulse becomes slower. The impulse becomes slow. Why it is slow, I'll tell you. It is because there should be some time gap for filling of the heart that is occurring during the diastole. So for filling of the heart, the AV node slows down, and if ECG cannot pick up this activity at the AV node, it becomes isoelectric line. I'll tell you what is ECG shortly from now. So we are discussing what? We are discussing properties of a cardiac muscle. In that first property that we discussed was, that I am discussing now, is automaticity. To understand automaticity, the automaticity is a property of SA node. The automatically the firing of action potential to cause depolarization by specialized cells called as SA node. They spontaneously depolarize. They spontaneously depolarize from -70 to -60 to -50 to -40 to -30 to -20 to -10 to 0. Then from 0 to +10 +10, again they come back repolarize. So these cells are spontaneously doing all this. These cells are spontaneously doing all this, and it is because of the property of the SA node. Hence we call it as the chief pacemaker of the heart. Chief pacemaker of the heart. We call it chief pacemaker of the heart, right? The SA node fires at a rate of 100 beats per minute or 100 depolarizations per minute. It has got an intrinsic rate. SA node has got a rate. This rate is important because this is the rate of the heart, which helps in one cardiac cycle, which helps in one stroke volume, and this helps in understanding if it is increased or decreased the underlying pathologies. You can call it tachyarrhythmia or bradyarrhythmia. All right. Then comes the AV node. AV node also has got a property of automaticity. AV node also has got a property of automaticity. But what will happen is this AV node here, it is the second most important pacemaker of the heart. The first most important pacemaker is SA node. Second most important, second highest pacemaker with a very, very high intrinsic rhythm of 40 to 60 beats per minute. It has got a firing rate of 40 to 60 beats per minute. Please remember that AV node always the depolarization is actually from SA node to AV node because the strength of depolarization is very, very high when compared to AV node. The strength of depolarization, the strength of electrical activity, the potential difference of SA node is very, very high. So always the AV node receives impulses from SA node. For example, say suppose there is a disorder wherein SA node has got a disease. SA node is not firing properly, or it is firing at a very, very high speed rate. What will happen is if SA node electrical activity comes down, still it is firing, but it is coming down, or very rapidly it is firing, AV node can generate its own impulse to give ventricular rhythm. So SA node rhythm arising from the SA node, you are calling it as sinus rhythm. The rhythm arising from the AV notional rhythm. So we have got two types of rhythms. Calling it as sinus rhythm. The rhythm arising from the AV node, you are calling it as junctional rhythm. How is this sinus rhythm and junctional rhythm diagnosed? We'll discuss that shortly from now. All right. Hope you understood this. After that, let us try to understand the importance of other cells, that is the Purkinje fibers, Purkinje cells. The Purkinje cells are the last cells to receive this impulse, I told you. The Purkinje cells are the last cells to receive this impulse, and they are not specialized for automaticity. Automaticity is not a property of Purkinje cells. Please remember this point. But why am I discussing this is they do have an intrinsic firing rate of nearly 35 beats per minute. This is more important for us. Sometimes what will happen is during the death of a person, first the SA node dies off. Then we get a heart rate arising only from the AV node. Heart rate slows down. After that, the heart rate arises only from the Purkinje cells. Slowly, the heart stops. This is what happens in the cardiac arrest. If you see the ECG, the changes will be first the AV node, the SA node is gone. So no P wave. Then the ventricle, that is a QRS complex only, ventricular depolarization will occur. Then what will happen? Only junctional rhythm. Then what will happen? Rapid ventricular rate will result in ventricular tachycardia. After that, only a twitches of the ventricle because you have done CPR or given adrenaline, epinephrine, some injection you have given. Because of that, what will happen is there will be firing of the Purkinje cells only, and slowly there will be a flat line. We'll discuss that when we'll be discussing ECG again. So next important property of cardiac muscle after automaticity is conduction. Conduction is nothing but the electrical impulse. It is traveling from one cell to another cell in the cardiac tissue. One cell to another cell in the cardiac tissue. That is conduction. Just a diagrammatic representation of different cells arranged like this. I'm just giving you a diagrammatic representation. Say suppose these are the cells. These cells will have gap junctions, and because of these gap junctions, the impulse will be moving from one cell to another in a linear fashion. So first this cell is getting depolarized, then this cell is getting depolarized, then this cell is getting depolarized. Then next cell is getting depolarized. So this is how the impulse is moving from one cell to another. This property of movement of impulse from one cell to another, you are calling it as conduction. Conduction. Please remember that AV node is very, very specialized for this conduction, and the conduction in the AV node is slow conduction. In the AV node, I already told you why conduction is slow in the AV node, because of one is increased gap junctions, and because of arrangement of cells, because of the compact arrangement of numerous cells, the rate of depolarization is slow when compared to the other cells of the heart, cardiac tissue. Alright, whereas exactly opposite is the fast conduction that is seen in Purkinje fibers, fastest conduction. So that a rapid systole occurs, systolic contraction occurs, because Purkinje fibers will have the fastest conduction. Purkinje fibers rapid conduction or fastest conduction because their diameter is large. They have got large diameter. They have got large diameter. These cells also express many gap junctions, and the rate of depolarization is rapid. All right. So in the AV node, we have got less number of gap junctions. I'm sorry, I told you high number of gap junctions. That is wrong. I'm very sorry. There is a correction here. It is the AV node has got less number of gap junctions. Hence the rate of depolarization is low, and arrangement of cells is so compact that the depolarization is slow. If the depolarization is slow, what will happen is the conduction is also slow here. The conduction is also slow here. All right. So another property of this cardiac muscle is contraction. That is, after depolarization, what will happen is the myocytes will undergo contraction, or there is a the excitation contraction coupling similar to the skeletal muscle. I told you about the differences and all, role of calcium and all I told you. So this is all about the properties: automaticity, conduction, and contraction. Now let us try to understand the action potential of the heart. Let us try to analyze and understand the action potential of the heart. Or cardiac action potential. Let us try to understand. Please remember that we'll discuss this in two forms. That is, we'll discuss the action potential of the non-nodal cells, and then we'll discuss the resting membrane potential of the non-nodal cells, because the firing of the SA node is different. Cardiac action potential of the SA node is different. We'll discuss that later. But first we'll discuss the cardiac action potential of the rest of the muscles. We are calling it as non-nodal fibers, non-nodal cells, or non-nodal action potential. We'll try to understand. Here, first the cell is in resting state. You are calling it as resting membrane potential, RMP. Then the cell is in active depolarization. We call it action potential of the non-nodal cell. So like this, we'll try to understand the two different potentials here. So resting membrane potential is because of potassium. So potassium, actually, there are ungated potassium channels. I told you different ion channels in my last class. So in that we have got ungated potassium channels. What is the function of these ungated potassium channels? They are always open. That too during depolarization. During depolarization they are open. Because during depolarization they are open, because during depolarization they are open, what will happen is the ungated potassium channels will undergo efflux to begin repolarization, to maintain the resting membrane potential. Because potassium has got very high conductance, I told you, very high conductance. In my last class I told you what is conductance in my before last class. So potassium ions have got a very high conductance because of presence of this channel, and the conductance is very high in case of ventricle, in case of atrium, and also in case of Purkinje cells. Because of this resting membrane potential, because the resting membrane potential is very close to the resting membrane potential of the heart is very close to the potassium equilibrium potential, the equilibrium potential of the potassium. So because of this high resting potassium conductance and because of equal, what will happen is the efflux of the potassium helps in bringing back the resting membrane potential, to minus 95 millivolts. This is what is the function of the ungated channel. We also have one more channel called as inward rectifying potassium channel. Potassium channels, IK. Alright, these are voltage gated channels. These are voltage gated channels and they are open at rest. They are open at rest. Depolarization closes this channel. And they open again once the repolarization starts. They open again once the repolarization starts. So please remember there are two types of channels: the ungated potassium channels, and the gated potassium channels, that is the inward potassium current, inward rectifying potassium channels. These two channels are very important to maintain the resting membrane potential. I told you we are discussing the action potential of the heart in the form of non-nodal cells or cardiac tissue, wherein we will be discussing resting membrane potential first, then we'll discussing the action potential. The action potential of the heart, to understand action potential of the heart, you need to understand the cardiac physiology as well as the ECG. Both you need to understand. We also have to understand the movement of ions from the cardiac muscle inside the cardiac cell and outside the cardiac cell. Inside the cardiac cell and outside. So three important points you should understand. To understand the action potential of the heart, you need to understand ECG, and also you need to understand the channels functioning. That is the sodium influx, potassium efflux. Alright, all this you should understand so as to understand this chapter as a whole. I'll be discussing simultaneously one after the other. Please remember, once we start understanding the action potential of the heart, I already told you that we are discussing non-nodal cells, means the cardiac tissue. The cardiac tissue which is do not have automatic rhythm, like the cardiac cells, the Purkinje cells, whereas the action potential which is formed by the nodal cells, the nodal tissue, nodal cells or the nodal fibers like SA node and AV node, it is different. We'll discuss that in the end. Please remember that the cardiac cells are electrically, they are connected to each other. I already told you diagrammatic representation. This is one cardiac cell, this is another cardiac cell, another cardiac cell, another cardiac cell, another cardiac cell, something like that. So they have got gap junctions, they are connected to each other because of this gap junctions. Because of this gap junction, if one cell firing occurs, it reaches the action potential, spreads across the neighboring cells. So from here the action potential moves to this cell, From here the action potential moves to this cell, then this cell, then this cell, something like that, neighboring cells. So please remember that at one point of time each cell is not, the group of cells are not depolarized at one time. So slowly the conduction starts. I'm saying slowly, it occurs in fraction of seconds. I'm just to exaggerate, to understand, I'm telling you, you cannot detect it because of in 1 second you cannot detect all this, but this is the property occurring with fraction of seconds. There is definitely a time delay. That is what you need to understand. Though we are unable to measure the exact time delay, but definitely there is a time delay. To understand cardiac action potential, you need to understand that there are 4 phases of cardiac action potential. We have got phase 0, phase 1, phase 2, phase 3 and phase 4. And phase 4. So phase 1, phase 2, phase 3 and phase 4. All right. So this is phase 0, phase 1, phase 2, phase 3 and phase 4. So we have got 4 phases of cardiac action potential. We are talking about cardiac tissue. The phase 0 is upstroke, rapid upstroke of depolarization. The phase 0 is rapid upstroke of depolarization. So phase 0 is rapid upstroke of action potential. I was just adjusting the screen, I'm sorry for repeating many times. So this phase 0 is nothing but because from one particular action potential from minus 95 millivolts, the action potential slowly rises because of entry of sodium channels. So high sodium conductance because of entry of sodium channels, because of opening up of sodium channels. Here the sodium channels which are opening up in phase 0 are the voltage gated sodium channels. The voltage gated sodium channels are opening. Because of this, the high conductance of sodium, what will happen is the cell starts gaining the positive charge and its action potential increases. It becomes 0. Then after that it becomes slightly more than 0. So the conduction velocity, if you talk about the conduction velocity, we know that sodium has got very high conductance. So the conduction velocity here is directly proportional to the rate of change in the slope of this graph. So how straight the slope is, the more is the conduction velocity. Please remember that certain drugs act on this area and they increase the conduction velocity, hence they increase the slope. All right. At this point of time, we get what is known as the QRS complex of ECG. The QRS complex. What is Q, what is R, what is S? I'll discuss that shortly from now. But please remember that this results in the QRS complex of ECG. This is all about phase 0. Next comes the phase 1. In case of phase 1, what's happening is the maximum depolarization has occurred. From phase 1, there is loss of potassium, loss of the positive charge, hence repolarization begins. So fall in the potential, fall in the action potential, because of, we all know that the sodium channels become inactivated and the potassium channels are open for efflux. So sodium channel inactivation followed by potassium efflux results in fall in the depolarized state and beginning of the repolarization. Next comes the phase 2. Phase 2 is nothing but slightly a plateau. phase 2 is nothing but slightly a plateau. So in this phase 2, what's happening is depolarization is because of the voltage gated calcium channels. Very, very important. The voltage gated calcium channels open up. Primarily, these are the L type of calcium channels, and this L type of calcium channels are open, and the voltage gated potassium channels are also open. What are the voltage gated potassium channels also called as? The inward rectifier current, IK channels. Inward rectifier currents of calcium, of potassium, I told you, IK channels. All right. For example, this results in inward movement of calcium, this influx of calcium. Because of this influx of calcium, again the cell regains the positive charge. The potassium channels are still moving out, efflux of the potassium, but the positive charge that is gained is remaining same, hence the graph remains same. In phase 2, the graph remains same and plateau. The influx of calcium, it triggers the release of calcium from the sarcoplasmic reticulum, and that causes contraction. That causes contraction of the muscle, the cross bridging, the excitation, contraction, coupling. I told you all this in my previous chapter. So all this will happen, and this plateau phase creates the ST segment. The ST segment is because of this plateau phase. The ST segment is because of this plateau phase. All right. If you see this, so this is the ST segment. The flat ST segment is because of the plateau phase. And what are the channels which are important in plateau phase? Two voltage gated, the calcium and potassium channel, that is inward rectifier current of potassium. These two are very, very important to perform the activity of the phase 2. Next comes the slope of phase 3, wherein the repolarization is continuous. The calcium channels are now closed. Efflux of potassium is continuing. Efflux of potassium is continuing. The calcium channels close in this phase. Repolarization, actual repolarization continues here, and the inward rectifier current of IK1 channels are open, and this creates a T wave in ECG. This creates a T wave. This is the relative refractory period. In the last class I talked about two types of refractory periods, the active refractory period and the relative refractory period I talked about. So this is all about the phase 3. Next comes the phase 4. Phase 4 is termed as resting membrane potential of the heart. The phase 4 is termed as resting membrane potential of the heart. Resting membrane potential of the heart, because it's a specialized tissue of automaticity, the cells of the heart are showing rapid depolarization. I'm talking about the pacemaker. So the cells of the pacemaker cells, the pacemaker depolarization is because of two important channels. The pacemaker depolarization is because of inward calcium currents, inward calcium channel. This is T type of calcium channel. Previously in the cardiac muscle tissue we had L type of calcium channel. Here this is T type of calcium channel. All right, T type of calcium channel, and this T type of calcium channel is different from L type of calcium channel because they open at a more negative resting membrane potential. At a minus 70 millivolts they open. They opens at minus 70 millivolt, hence they are different from L type of, because L type of calcium channels, they are opening only in the repolarization phase. Only in the repolarization phase they are opening, is it not? So this helps us in understanding the action potential. To understand action potential of pacemaker, one more important channel to understand action potential of pacemaker is the inward sodium channel. The inward sodium channel has got an important property. We call it funny channel, funny current. Hence we denote it IF, inward funny current. Because this channel is involved in one important property of hyperpolarization. So hyperpolarization activated channel, this is a non-selective channel wherein what will happen is both sodium and potassium can move inside. But the important point is, because this channel, once this channel is open, this channel is open when the membrane repolarizes, when there is negative membrane potential. So repolarization opens this channel. Repolarization actually opens this channel, and depolarization closes this channel. Depolarization actually closes this channel. Alright, depolarization closes this channel. We have one more important channel related to potassium. We call it outward potassium current. We are discussing what? We are discussing action potential of a pacemaker cell. In that, 3 channels I have discussed: the calcium, invert sodium, funny channel, and we have got outward or efflux type of potassium channel. The movement of potassium outside is repolarizing the cell. We all know this point. So as the repolarization occurs, at the peak of repolarization starts. So beginning of repolarization or initiation of repolarization, what happens is the potassium channels open. In outward potassium channels open. So this helps to produce pacemaker potential. Now how is this pacemaker potential? Let us try to understand. With the help of a diagram, let us try to understand. The SA nodal potential is something like this. The SA node potential is something like this. So we have got, say suppose this is minus 60 millivolt. So it begins at minus 60 millivolt like this. It rises. Then the phase 0 of depolarization starts. Something like this. So this is the phase 0. This is the phase 4. It has got no phase 1 and 2, or rapid phase 1 and 2 clubbed together as phase 3. Alright. So say suppose at this point we have got 0. So all these are 50, 40, 30, 20, 10, 50, minus 40, minus 30, minus 20, and minus 10. Then 0. So something like this. All right. So this is the action potential of a SA nodal cell. Pacemaker action potential. It is because of the inward calcium current, the T type, inward sodium channels, which are funny channels. We are calling it funny because it is causing hyperpolarization, and it is non-selective channel. And the third important point is outward potassium channel. Note that the phase 1 and 2 are absent in SA node depolarization. What are the phases which are absent in SA node depolarization? Phase 1 and phase 2 are absent here. Is it not? Phase 1 and phase 2 are absent here. Now with the help of a diagram, I'll try to explain you again what I have taught with the help of a picture representation. I'll try to understand. I'll try to make you understand. Yes. The cardiac action potential. So 2 types of action potentials we discussed: the cardiac cell or myocyte action potential. Myocyte action potential we discussed, and we also discussed the pacemaker action potential. Pacemaker action potential, is it not? Pacemaker action potential. Here the phase 0 is upstroke or rapid depolarization. Phase 0 is upstroke or rapid depolarization. It is because of opening up of the sodium channels. Then comes the phase 1, that is early rapid repolarization. Early rapid repolarization because of the potassium channels, ungated potassium channels. The plateau phase is very, very important. It is because of voltage gated calcium channels, which are L type, and inward potassium currents, inward potassium channels. Inward potassium channels, please remember this point. Inward potassium channels, all right. The final rapid depolarization is because of efflux of potassium and closing up of calcium, and then comes the resting membrane potential and diastolic depolarization. All right, diastolic depolarization. Diastolic depolarization. I'll show you one more important point here. With the help of a this diagram, I would like to show you one important concept here. So on the extreme right top of your screen, you have got SA node. These are the sinoatrial nodes cells. So we have got two types of action potential. The first type is the pacemaker action potential in this diagram. The second is contractile myocardium or the cardiac tissue. Here you can see that depolarization followed by repolarization. That's it. In case of point number 1. In case of point number 2 here, we have got the contractile myocardium showing phase 0 of depolarization, then phase 1, that is rapid repolarization, then phase 2, that is plateau phase, then phase 3, that is continuation of repolarization, then phase 4, that is resting membrane potential. If you can see throughout this cardiac cycle of contractile myocardium, the potassium channels are open. The potassium efflux is open throughout. One point you can remember, from phase 0 to phase 4, 1, 2, 3, 4, all these potassium channels are always open. Hence we are calling it as the ungated potassium channels which are open. What the important point to remember is phase 0 of depolarization is because of influx of sodium. Phase 0 is because of influx of sodium. Phase 1 is because of efflux of potassium. Phase 2 is because of influx of calcium. Phase 3 and 4 are because of efflux of potassium. The next diagram which I want you to understand is the pathway of conduction, that is the SA node, the AV node and the Purkinje fibers. If you can see the point number 1 here, the SA node depolarization is something like this. Next comes the atrial depolarization, point number 2 is something like this. Phase 0, it has got a rapid upstroke phase 0, atrium, and no plateau phase in atria also. In AV node is a slow conduction. Is it not? Slow conduction because of less gap junctions and because of compact cells, high number of compact cells and less gap junction. All right. So AV node has got a slow conduction. Next comes the Purkinje fiber, and Purkinje fiber and the cardiac muscle have got the similar action potential of phase 0, 1, 2, 3 and 4. Of phase 0, 1, 2, 3 and 4. Next, if you try to understand the ventricular action potential here, the ventricular action potential, endo is the endocardium, epi is the epicardium. All right, this is the action potential of the ventricle. And in the bottom you see ECG lead 1, the bottommost diagram here. This is representing the importance of ECG and the events of cardiac cycle. So what are the events of cardiac cycle? SA node firing causing atrial systole, then the current moves to the AV node, then from here to the bundle of His, then ventricular firing, ventricular depolarization followed by ventricular repolarization. Ventricular repolarization is followed by another SA node firing. So this is the cardiac cycle that you need to understand. This is the cardiac cycle, and this ECG you need to understand. The SA node firing is represented by the P wave, The AV node is represented by the PR segment. The bundle of His causing depolarization of the ventricle is represented by the QRS complex. The ventricular repolarization is represented by the T wave. You can ask me one point, sir, atrial repolarization or SA node firing, atrial depolarization or SA node firing is P wave, ventricular depolarization is QRS, ventricular repolarization is T wave. But what about the atrial atrial repolarization? Atrial repolarization also occurs, but we are unable to detect it because of QRS complex. So what is this ECG all about, and how are we going to understand this ECG? Let us try to begin our discussion of ECG now. Hope you have understood the phase 1, phase 2, phase 3 and phase 4 of phase 1, phase 2, phase 3, phase 4 of the cardiac action potential. With this, now let us try to understand the electrocardiology or electrocardiogram. As I already told you, that ECG is nothing but, the electrocardiography is nothing but, it is a graphical representation of, it is a graphical representation of the cardiac events. The cardiac event, the first cardiac event begins with the SA node, firing of the SA node. That causes atrial depolarization, and this results in P wave. Atrial depolarization, which results in P wave. All right. So the atrial depolarization results in P wave. P wave here is atrial depolarization. This is followed by the QRS complex. So we have got a P wave, we have got QRS complex, we have got T wave. Please remember, so ECG actually is a graphical representation. A graph has got a x-axis and a y-axis, is it not? So we'll try to understand what is normal ECG now. To understand normal ECG, we need to understand that ECG recording is a graphical recording. What are we recording? You are recording the potential difference. You are recording the potential difference of the cardiac muscle. The firing of the SA node, AV node, Purkinje fibers, bundle of His and all, you are trying to understand. We all know that phase 0 produces QRS, phase 3 produces the T wave, and the ST segment is phase 2. Just now I told you about 4 phases. So to understand this, we need to understand standard conventions of ECG. So say suppose this is the ECG paper. Say suppose this is a ECG paper. I don't know whether the quality of this paper video is good or not. I'll try to shorten it. Adjust the quality, please wait. All right. So as long as you are seeing the big boxes here, that's okay. That's well and good for me. So I'll tell you what is a big box and what is a small box. So this is a big box. You call it, this is a big box. I'll select some other color. I'll select a green color to make it highlight. This is a big box or a large box. It's a square, is it not? So this is a large box. And each large box has got, see, this is a small box, this is a small box, this is a small box. So like that, each we have got, these are the small boxes. Please remember that ECG is a graphical representation. A graph has got x-axis and a y-axis. On the y-axis, So on this axis, you are recording the potential difference, voltage difference or potential difference you are recording. On x-axis, you are recording time. On x-axis here, you are recording the time in seconds or milliseconds, seconds, milliseconds, or whatever you want. You can try to understand. First, we'll see seconds only so that you understand it better. So y-axis in this paper. So the y-axis is voltage difference and x-axis is time. So when I say voltage difference, we have got a large box. Each large box, a large box on y-axis, a large box on y-axis represents 0.5 millivolts. 0.5 millivolts. All right. And the x-axis, one big box or a large box on x-axis represents 0.2 seconds. So this is the convention you need to understand. This is the adjustment of a machine. Sir, how are you saying this 2.2 seconds and all? We all know that ECG runs at a speed of 25 millimeters per second. 25 millimeters per second. And we all know that each large box is 5 millimeters in length. 5 mm in length and 5 mm in height. It's a square. So length and height are equal, 5 mm in length and 5 mm in height. So each large box has got 5 into 5, 25 small boxes of 1 millimeter square area. All right. This is the convention you need to understand. So because there are 5 divisions of a big box, so if you divide this large box into again 5 divided by 5, so each small box, the time period of each small box or 1 mm time difference is 0.04 second. So how did I come to this conclusion? If the ECG paper is running at a speed of 25 millimeters per second, then you can easily calculate for 1 millimeter how many seconds. It will be 1 divided by 25, is it not? Similarly, you can also call it 40 milliseconds. You can call it 40 milliseconds. 40 milliseconds. All right, like this you can give number of points to understand. So one large box is equal to 0.2 seconds. One large box equals to 0.2 seconds. And one small box is equal to 0.04 seconds. 0.04 seconds. Or you can also say that 5 large boxes make 1 second. 5 large boxes make 1 second. If you talk about the x-axis is time, y-axis is potential difference, you call it. Height of the potential difference, you are calling it as amplitude. The amplitude is set such that 10 mm is 1 millivolt, or each large box is 0.5 millivolts, right? So if you see this ECG, in this ECG, if I ask you what is the amplitude, in this ECG, if I ask you what is the amplitude of, so this is the P wave, all right? This is the Q wave, this is the R wave, this is the S wave, and this is the T wave. In between, we have got the PR segment, the ST segment, the QT interval. All these definitions we need to understand based on the ECG finding. All right. So to read an ECG, the first step that you need to do is, we all know that why P wave is a positive wave here, because of atrial depolarization. So I'll write again what I made you to understand. The P wave is because of atrial depolarization. It is occurring because of the activity of SA node. Then comes the PR segment. The PR segment is isoelectric. Why is it isoelectric? Because here the current is passing from SA node, the current is going to AV node. So this causes AV node depolarization. And we know that AV nodal depolarization is slow. AV nodal depolarization, because of less gap junctions, it is slow, and it is helping the filling up of ventricles. We all know this point. Next comes the QRS complex. The QRS complex is because of ventricular depolarization. Ventricular depolarization. The QRS complex because of ventricular depolarization. Then comes the ST segment. The ST segment is isoelectric because of the refractory period that occurs in phase 3 of ventricular depolarization. Phase 3 of ventricular depolarization. Then comes the T wave. The T wave is because of ventricular repolarization. Ventricular repolarization. The T wave is because of ventricular repolarization. So this is all about the ECG. How to read an ECG? Let us try to understand. To read an ECG, first you need to determine the rate of the heart rate. To determine the heart rate, you need to understand that the ECG runs at a speed of 25 millimeters per second. So heart rate is measured in beats per minute. All right. Each QRS complex in this ECG. So each QRS complex is one ventricular depolarization. From P wave, QRST, all these waves, this represents one heartbeat. One heartbeat. So what you need to do is, you need to calculate in between the two heartbeats. So this is one heartbeat and this is one heartbeat. So in between the two R waves, RR interval we call it. In this RR interval, you need to calculate the number of big boxes. The number of big boxes in between the two RR intervals you need to calculate. So in this diagram, if you see, there are 1, 2, 3, 4, 5. So this is one big box. I'll try to draw it with this black color. So this is first big box, second big box, third big box, fourth big box, fifth big box. So roughly, please remember that 300 divided by number of big boxes or 1500 divided by number of small boxes. This is the formula for heart rate, calculation of the heart rate. How did I come to this conclusion? 300 divided by number of big boxes, 300 divided by number of big boxes, or 1500 divided by number of small boxes. How did I come to conclusion? I came to conclusion because of this ECG rate. The rate of movement of the ECG paper is 25 millimeters per second. Because of this, we need to understand that in per minute, so it makes 5 boxes per minute, is it not? Per second. All right, 25 mm means 5 big boxes per minute, per second. So each second, 5 big boxes. So each minute, it will be 300 big boxes. So 300 big boxes make a minute, is it not? 300 big boxes on x-axis, they are making a minute. So if you want to calculate heart rate in a minute, you have to divide 300 divided by number of big boxes in between each RR interval. Or small boxes is 300 into 25. So it is 1500 divided by number of small boxes. This gives the heart rate. All right. Next comes, so this is the step 1. Step 1 of ECG is to read the rate. I'll give you example also. Step 2 is rhythm. Step 2 is rhythm. How to calculate the rhythm? So rhythm is of two types. Rhythm means the impulse generation. Impulse generation means what is the first site of depolarization? Is it SA node to call it sinus rhythm, or is it AV node to call it junctional rhythm? SA node means each QRS complex is preceded by a P wave. In the ECG, if you see, if P wave is present, it means sinus node is present, working. We call it sinus rhythm. If P waves are absent, it means that if P wave is absent, it means that only QRS complexes are present. It means that SA node is not firing at all. Only QRS complexes are present. That is called as junctional rhythm, AV junction or a junctional rhythm. All right. So first step is to understand the rate. Second step is to understand to calculate the rhythm. Third step is to understand the waves. So you have to look at the waves, whether P wave is present or not, QRS complex is normally present or not, T wave is present or not. How do they look normal? Then you will appreciate what is abnormality. In one video, I'll teach you whole of the ECG, abnormal and normal ECG. I'll make a video for you, and in that I'll be teaching, because this is the physiology, I'm teaching only normal values. All right. So third important step is to understand waves. Here the most important waves like P waves. P wave is equal to number of 2 to 3 small boxes in. So this is the normal width of the P wave, 2 to 3 small boxes. All right. Then the QRS complex is also 2 to 3 small boxes. If it is more than 3, you are calling it as wide QRS. Less than 2, you are calling it as narrow QRS complex. Then fourth important step is to read PR interval. PR interval helps you to understand the functioning of the AV node. The normal PR interval is equal to 3 to 5 small boxes. So normal PR interval is equal to how many milliseconds? See, each small box is 0.04 milliseconds. So 0.12 to 0.20 seconds, is it not? So each small box, I already told you, each small box is 0.04 seconds. Each small box is 0.04 seconds. So if they ask you what is the duration of normal PR interval, duration of normal PR interval means 3 into 0.04. 3 into 0.04 or 5 into 0.04. It is 3 to 5 small boxes, is it not? So it comes to around 0.12 to 0.20 seconds. So this is the important estimation of ECG. We also have estimation of electrical axis of the ECG. What is electrical axis of the ECG? To understand this, you need to understand the leads, which is beyond the purview of this class. I'll take one class on ECG alone and I'll try to teach the axis of ECG. So we have to determine whether it is left axis, right axis, or extreme axis deviation, something like that. And at the same time, we need to understand whether because of this axis, whether the blood flow is stopped or some myocardial infarction has occurred, ST segment elevated or something like that. Or we need to understand whether the heart rate is slow or fast based on the rate. So I'll give you one example of ECG now, and you should tell me what is this ECG all about. Now this is the example of ECG in front of you. So how to calculate heart rate of this ECG? You should tell me what is the rhythm of this ECG. You should tell me what are the waves looking like. Please remember, heart rate you calculate in terms of 300 divided by number of big boxes in between the 2 hour interval. 300 divided by number of big boxes. So in between 2 hour, if you see lead 1 here, so this is first hour, this is second hour. In between these two, we have hardly one big box. So here the rate is very, very fast. And in this, are you able to see P waves? P waves are absent in this ECG. P waves are absent. So it's a junctional rhythm. It's a junctional tachycardia. You can call it junctional tachycardia. This is the diagnosis of this ECG in front of you. So you can pause the video and you can try to understand what I am saying. So if you see the heart rate is very, very fast here, more than 150, and P waves are absent, so junctional tachycardia. So this person is actually having an arrhythmia. This is an example of one ECG, abnormal ECG I'm telling you. We have completed the understanding of electrical activity of the heart. Hope you have understood the topic. In some other separate class of general medicine, I'll be teaching you what are the important findings of an ECG, how to interpret ECG, and how to understand the various abnormalities of the ECG. Just by seeing the ECG, you will be able to diagnose in your hospital various diseases. So with this, we have come to a conclusion. Thank you very much. If you have any doubt, please ask me. Feel free to ask. You can email, or you can call me, or I'll be very, very happy to help you. All right. Thank you so much. Good night.